why we recommend yogurt, because it has a natural bacteria that help to replenish the bacteria in our intestine. But that can also fight infection. Our neutrophils, again, is part of our immediate response. They show up, they're the ones that show up first. They're the ones that are the most numerous. Our antigen presenting cells. Are you clear on the whole antigen epitope concept? Okay. The antigen is like an immunoglobulin. We've got what are the different ones we have? We got G, C, M, A, D, but those are actually the parts of our body that are attaching to the cell and identifying them as an invasive. The epitope is the part of the cell that they actually say, this is the part that I'm connecting to. And you see where I was doing the animation? We have a very specific shaped antigen, and it'll attach to a part of the cell that fits exactly. That's the epitope and the antigen. Okay.
Of the macrophage or of the bacteria?
Macrophages tend to devour it.
So
They don't do that
what
connection.
is the epitope on? Is it on
The epitope is actually on invading bacteria.
on bacteria? Okay.
Okay. Our adaptive part of our immunity is basically where we're developing memories of the different bacteria so our body can remember them the next time. We create lymphocytes, they split into B cells or T cells. And there's a lot of different kinds, but the ones I want you to remember, for one, the helper T cells. These T4, CD4, the helper cells, and the natural killer cells and the cytotoxic cells. The B cells are actually the ones that become antibodies. Our lymph system, it's fairly involved. It's all over. Our lymph nodes are part of it. That's where we have a lot of our white blood cells, and that's what we use to fight. So those helper T cells will report right to the lymph nodes to identify an invading organism so that they can fight it. Our lymph system is also one of the things that pulls additional fluid out of our body and brings it back and sticks it into the circulation so our body can dispose of it. Sometimes lymph systems get out of control. I had a good friend that had a terrible case of this. She was a wonderful lady, she was beautiful, and all of a sudden both of her legs swole up. And then it spread in both of her arms. It was all she could do to get around. Nicest lady I ever met. Terrible condition. This is a little involved, but not too. It's more informative than anything else. Your B lymphocytes, 30 to 40% of your lymphocytes. Your T lymphocytes are the most numerous. There's more of those. Those have the CD8 and the CD4. Those are T lymphocytes. They mature in the thymus. Your granulocytes, like for example your neutrophils, those are the most numerous. Your eosinophils and basophils, a lot of times those are connected to like an allergic reaction. Your eosinophils will increase in number if you have an allergic reaction. And mast cells are a part of your response to that. And monocytes and macrophages, those are the ones we were talking about that actually engulf and devour the invading bacteria. Cytokines. They're basically the portions of our immune system that make the communication. They're working in between the cells to help dispose of any invading factor. Tumor necrosis factor, relatively involved, but I just want you to understand that the tumor necrosis factor contributes to inflammation. If you're blocking the tumor necrosis factor, you're reducing inflammation. What's the regulator, Jenna? Interferons, interferon, okay. Erythropoietin. If somebody has low red blood cells for whatever reason, either they're not making them fast enough or they're being destroyed for some reason, we can give them erythropoietin, and that'll help them to reproduce more red blood cells. Next slide. Okay, those antibodies that we were talking about. You see the immunoglobulin M, that's your macrophage. That's a big one. Immunoglobulin G, E, D, A. I'm going to those in just a minute, what they do and where they do it. All right. Immunoglobulin M is primarily found in your blood. And you can see here, your M is blue. Wherever you see the blue, like your heart, your vessels, you're going to see immunoglobulin M. Immunoglobulin G is primarily in your tissues. See? G is flesh colored, so you've got it in all your tissues. Immunoglobulin A is in your mucosa. So if you have a mouth infection, your immunoglobulin A is going to be increased. Okay, yeah. See, it's yellow. You've got the yellow parts here. It's in your intestinal system, your mucosa. And immunoglobulin E, we were talking about, remember, it contributes to inflammation when you have an allergic reaction. This would be a good one to remember. If you don't have the antibodies, if you don't have the immunoglobulins, you can get them. You can inject them. Works well. It's temporary. Our immunoglobulins work all the time. If your immune system is suppressed and you need them, you can get them. Artificial. So we'll talk about the difference between artificial and what's the other part? What do we have at natural? If you have immunoglobulin A deficiency, remember we're talking about mucosa, so eyes and ears, sinuses, lungs, GI infections. That's probably what we're going to be running into. We get a lot of our immunoglobulin A from our mom when we're breastfeeding. So what happens if mothers aren't breastfeeding their children? They have a reduced immune response because they don't have that natural immunity that they got from their mothers. Some mothers cannot breastfeed for whatever reason. This is a B cell concentrating. See, you've got your immune globulin here, and it's an antigen. It's identified an invader, the allergen, and the B cell becomes a plasma cell and overproduces immune globulin E. And you've got, it becomes a mast cell, and mast cells actually become macrophages. It creates mast cells so that you can do that. And it fights the symptoms. And here you've got your macrophage engulfing the invading species and getting rid of it. Occurs in nature. It's natural. It's created by humans. It's not natural. Antibodies are made by the body. It's natural. Antibodies are not made by the body. It's passive. Here's a diagram we can look at to help identify that. So if something is active, natural, for example, measles, we get that, we will make our own antibodies to resist it. If it's artificial but active, active means our body is working, it's doing something to create this. Naturally, we would make our own resistance. Artificially is when we get a shot, if we get what's the word I'm looking for? An immunization. That would be active artificial, because our body is working to create the response. Passive natural, it's natural to breastfeed from our mother. So this is, but it is passive, it's not an immunity that we're making on our own. Artificial passive, like that immune globulin that we were talking about. Yeah. Nice one. Vitamin D enhances our immune system. Where do we get vitamin D? Sun. So if somebody is stuck inside all the time, their resistance, their immune system is decreased. They're at a higher risk. They don't get that vitamin D, among other things. People that are stuck inside all the time also tend to have poorer diets, so their diet is deficient. All right, we're assessing our patient. We want to assess the immune system. The different portions of the immune system we were talking about, different parts of our body, they should all be assessed. Talk about their chief complaint. For example, the guy that we looked at. Why was he coming in? What their past medical history was. Any allergies they have, because we want to identify allergies up front. What kind of allergies they are. If they had any of their childhood diseases, if they have them all. If they have recent immunizations. If they have any malignancies going on. If they are autoimmune diseases, and we'll talk about those a little bit later. Anybody give me an example of an autoimmune disease? HIV, that's one. What's another one?
I said type 1 diabetes.
Type 1 diabetes? Okay. How about another one?
Celiac.
Raise your hand.
Celiac.
Celiac, yeah. Good. What's another one?
Psoriasis. Psoriasis.
Psoriasis.
I know, we'll just say what we have.
Are they taking any immune suppressants? One of the problems you run into with an autoimmune disease, the medications that you take for it put you at a higher risk for infection. For example, if somebody is taking an autoimmune medication, they're less likely to need to go out in public, or they shouldn't be going out in public, because they're more at risk to catch anything from somebody that they meet. If they have a family history of an autoimmune disease, or a social history, like HIV. As people get older, their immune system decreases. So people who are older are at a higher risk for infection. Some of the things we might see when we're looking for our immune system compromise. How about that one on the top left? What does that look like? That's the butterfly rash. What does that tell us? Could be a lupus thing. Might not. But it could be. Rashes on the hands, rashes on the cheeks, rashes all over their chest. So if we see a patient like this, the questions that we ask him should be specific to what we think it might be. But we don't want to focus on it completely. We want to ask wide enough questions that they can give the answers that are appropriate as opposed to narrowing it too quickly. How about this one? You almost always see this in an adult, usually an older adult. Very frequently an adult who has had, what does that come from? Chicken pox. Usually an adult who had chicken pox in the past. Shingles usually shows up as a result of stress. And I'm told I had shingles once when I was under a whole bunch of stress, and I was told it was really painful. It was uncomfortable. Some people, it's very painful. Why are they in stripes? See these, they kind of follow a strip pattern. They follow the dermatitis, the nerve patterns, right? What's this one?
Arthritis.
Very likely rheumatoid arthritis. A lot of people have this. This is common. You get older and you run into this. It is an autoimmune disease. How about this one? Thrush. What can we do with that? Yasumi. What can we do with thrush? Anybody help her?
Antifungals. Antifungals.
Antifungal. Good. Okay. What kind of antifungal? Nystatin. And there's a difference of opinion. Some people say swish and swallow. I think swish and spit would be better.
Yeah.
But some hospitals say swish and swallow.
Also, I've seen that they've started using chlorhexidine mouthwash too.
They're trying to, yeah. Alright, so we'll listen to their heart, lungs, and abdomen. We're gonna palpate and percuss. Which do we do first? We got a stomach issue going on. What do we do first? Push, percuss, auscultate.
You inspect, auscultate.
First we look at it,
Yeah.
and we auscultate. Good. The less invasive one we start with. Because you can actually change the sound by palpating their abdomen. When you guys did the physical assessment, did you have the opportunity to identify different organs in your partner's abdomen? That would have been part of your total, when you get a chance, practice. If you have a spouse that's willing, let you practice. You can find where they're, if you're good, you can find where their intestines are, you can identify their abdomen, you might be able to feel their abdominal aorta. How can we identify, how can we evaluate their thymus? What happens if you palpate the thymus? Thyroid, thymus. Thyroid, thymus. You can actually cause more problems. Squeeze it. Lymph nodes. You see where the lymph nodes are? You done one of those lymph? In fact, I see most of you do the lymph node checks. You guys do that pretty well. You must have picked it up in the second quarter, huh? Still there. How to palpate the lymph nodes. This is a pretty good diagram. The way they do that, it pretty much gets all of them. What do you do if you can identify some of the lymph nodes are full, swollen? Lisa, you're palpating my lymph nodes, and the ones over here are a little big and they're kind of hard. What do you do? How do you feel? Is that painful? A little uncomfortable. Okay. Have you been sick? How long do you have them? Usually, if you have a mild infection, and this is interesting, all right, you guys have probably already identified it, but your lymph nodes, where do we find them? Here, here, here. They're wherever you have an extremity that joins the trunk of your body. Because you have extra white blood cells in there, they help fight infection before it gets into the central part of your body. So if you have lymph nodes, chances are you have an infection peripheral to that. You have swollen lymph nodes here, you might have had an infection down this arm. So that would be an area for questioning. Have you had a recent damage or injury on your arms? Oh yeah, actually I poked myself on a wild rusty nail. Okay, our CBC with a differential. Differential means they're counting each of the different constituents. Neutrophils, that's the big one, 45 to 73%. That's about where they should be. They'll go up and down, depending on the situation of the patient. Your bands are usually 0 to 3%, very low. They go up, it tells you the body is in the process of making more white blood cells because of an infection. Monocytes, 2 to 8% lymphs, 20 to 40%. Eosinophils, usually less than 4%. If you have an elevated eosinophil count, what does that tell you?
Allergy.
Probably an allergy, an allergic reaction of some kind. Neutrophils decrease with chemotherapy. It kills white blood cells. So if you have a patient who is getting chemotherapy, they have fewer white blood cells, it elevates their risk for infection. Hypersensitivity reaction from the eosinophils. Pandemia, kind of the same thing. Cool, slide though. If you have elevated bands, you have a new infection and your body's working to fight it. It's a little different in kids. I wanted you to be aware of it. I want you to look at this and remember, it's not gonna be on the test. I just want you to understand that it's different in kids than it is in adults. Anti-nuclear antibodies. It's usually one of the primary tests they use to identify an autoimmune disease. That would be a good one to remember. SLE is systemic lupus erythematosus. Okay, lupus. CRP, one of the other tests they use to identify it. C-reactive protein. And it's a pretty specific, non-specific indicator of inflammation. But it's used for a lot of different things. One of them is for infection and inflammation. You see a lot of doctors will order a CRP for a heart problem. Erythrocyte sedimentation rate. It's how far your red blood cells will fall in 1 hour. It's also an indicator of an inflammation. Will it tell you where the inflammation is or what kind of inflammation it is? No. Some of the different factors that can affect your ESR. Rheumatoid factor has to do with the immune globulin N and the immune globulin A. This is way involved. I'm not sure how much we really need to know all that. I understand that it's natural in a lot of older people. If you see an elevated rheumatoid factor, it may not be an indication of rheumatoid arthritis. This is a good one to remember. Your hypersensitivity reactions, type 1, 2, 3, and 4. There's even a mnemonic. Type 1, A, B, C, D. Type 1 is A, allergic, anaphylaxis, and atopy. Who can tell me what atopy is? I forgot, somebody look it up. Type 2, B, antibody response. Type 3, and I've opened this up on Canvas if you guys want to go back and look at it. C, immune complex issue. Type 4, D, delayed reaction.
Open up the airways. It's going.
What was it?
I'm trying to search the info, what then it brought me to,
What'd you find out?
no, I can't read it.
Okay. A little more information on that same subject, type 1, 2, 3, and 4, A, B, C, and D. And it talks about when they show up. If you have a type 1, it's allergic rhinitis. What's rhinitis? Okay, like a nasal infection, right? Asthma, systemic anaphylaxis. Type 2, you see it in a lot of drug allergies. If you have an allergic reaction to a drug medication. Type 3, you see it in serum sickness. And type 4, usually a contact dermatitis issue. And again, that would be a good one to remember. For example, this is kind of interesting. They usually do it with hair dye because some people are allergic to certain kinds of dyes. Before they dye your hair, they'll try just a little bit of it behind your ear. This lady had definitely an allergic reaction to it, so I'm guessing she's not going to want to use that hair dye. Which one is it? Type 1, type 2, type 3, or type 4?
Type 4.
Which one? Type 4, contact dermatitis. It was on her skin. Woohoo! Good job. There's some kind of scary ways. If somebody is just sick all the time, they have a lot of allergic reactions, they can actually put little bits of each of those under the skin. I've seen them do it on the back. I've never seen one on the arm before, but I've seen them do a bunch of them on the back, so they can identify which one is actually causing the reaction. And That way that person can eliminate it from their life as much as possible to avoid the problems. That is interesting. Terrible way to have to do it, yes.
I had it on my arm.
Yeah,
I think having on the back would be easier because one of them swelled up so much and I wanna scrap it, so
it's harder to get to your back.
I would suggest your patient to do their back.
And a lot of times you see kids that just seem like they're sick all the time, it's probably an allergy issue. So you take them to a dermatologist and get this done. Find the problem. And you know, kid, he's subject to a lot of my stories, but he had a lot of allergies and he was sick all the time. One of the things they ran into was that he loved to drink Coca-Cola, and his parents would just let him drink as much Coke as he could. One of the things Coca-Cola does is it decreases bone density. So from the time he was about 7 years old, every time he turned around, he was breaking another bone. And then they went and got this dermatology test done, and they found out he had like 15 different allergies. One of them, guess what it was? Coca-Cola. Guess what? He still drinks Coke. Perfect example of an immediate hypersensitivity reaction. Which one would that be? Type 1, 2, 3, or 4? Still 4. It's on the skin, right? Contact.
But it's not contact dermatitis.
What if it's like a penicillin?
That's type 2.
Syrup, right?
Yeah. But
Okay.
that's not, that's just because it's on the skin doesn't mean that it's necessarily type 4.
Cause
If
that's
you
what
have,
atopic
and
means.
again, just because it's on the skin, it doesn't have to be type 4.
Yeah.
But that's usually where we see it, because that's the part that's most obvious. Say you're giving somebody an antibiotic, penicillin, for example, yes, go ahead.
I was just gonna say, like, would that be like the hives that you get with like allergic reaction?
Absolutely, yeah. There's a reaction called red man syndrome, that's specific to penicillin. Yes, Amy?
I was gonna say, that's what atopic means, that in type
It's
one.
not topical.
No, it means that you have an allergic reaction with a part of the body that is not related to or not in contact with the allergy. So you inhale something, you eat something, and your skin reacts. That would still be type 1.
Allergic rhinitis, asthma, systemic. So that sounds like more respiratory, so we're talking about mucus, right?
Right, but if you go back one more side, you had that allergic anaphylaxis atopy. And atopy means that it's related to the allergen but not in contact to it. So you could still get a type 1 reaction on your skin, but don't come into contact with the allergen on your skin.
Sounds logical.
Yeah, and also like that slide that we're looking at with like the rash on the arm, it says type 1 and it says GI stuff like nausea, vomiting, diarrhea, and respiratory. That's pretty systemic sounding to me. So that definitely relates to the immune-mediated hypersensitivity slide, which is the next slide. So systemic anaphylaxis.
Works. I agree.
I was looking online and like they were saying that the type 1 is something more kind of like a bee sting, whereas like the type 4 would be like a PPD test that they do. So it's a later response, a delayed response from 2 days over.
Okay. I love when we learn. Okay. Backing up just a little bit. Patients getting an IV. You have their vital signs were good. They start the antibiotic, all of a sudden they start to get short of breath and they're itching right at the site where it goes in. What do you do? Stop the IV.
Find out what the, whatever drug it is, like,
stop the IV, that's good, we don't want them to get any more of that if that's a problem. What's one of the things that you run into if you have an allergic reaction like that? Airway issues, right? So you wanna get somebody right away, with like an antihistamine, just Benadryl or something, to help control that. Cause we wanna avoid those respiratory problems as much as we can. Symptoms of anaphylaxis, loss of consciousness, that would be like a later symptom. Usually as a result of not enough air. Angioedema, that swelling of the mouth and face. I've got a slide on that. Hypotension, like shock. Blood vessels expand, so we get low blood pressure. Angioedema. There's a real clear case, but sometimes it won't be that obvious. Stop exposure to the cause. So when you get an IV antibiotic, stop it. Make sure their airway is clear. Like I say, one of the things we can do is call for some kind of an antihistamine. We want people to know right away this person is at risk. Watch their breathing, their circulation. If they're getting an allergic reaction, like I say, their blood pressure will probably be dropping. Epinephrine, absolutely. You guys know about the EpiPen thing? I've got some samples. One is the round one. What's another name for epinephrine? Adrenaline. It also heads off allergic reactions fast. How long does it last? Like 20 minutes? 20 minutes? 20 minutes. 5 or 10. They recommend that people that have an allergy like that, like a peanut allergy, have an EpiPen with them all the time, just in case. I say 2. Because once you get that reaction, you gotta get to the hospital. If you don't make it to the hospital quick enough, you might have the whole thing start all over. How many times do you wanna hit yourself with epinephrine? Maximum of 2. It's adrenaline, and it can cause heart problems. But airway, get that cardiac going later. The antihistamines, diphenhydramine, also known as Benadryl, famotidine, I think that's a leg drug. But they work, it actually just controls the symptoms. It doesn't stop the reaction. It just helps control symptoms, like improve your airway. Corticosteroids, what do? Huge anti-inflammatories. A corticosteroid would also be helpful. Steroids are wonderful. They do amazing stuff. They're a terrible drug. Yes.
Another thing is, Pepsin, not Allegra.
Is it Pepsi? The long-term steroids do terrible things to your body. It messes up all your hormones. Increases your risk for, it suppresses your immune system, so it increases your risk for infection. It makes your bones more brittle. It can cause airway issues. It can give you a humpback. It can cause swelling. Prednisone, wonderful, terrible. Cytotoxic hypersensitivity. If your body identifies an antigen that's foreign, it creates complement proteins which cause cell lysis. Like, for example, a blood transfusion. And this is interesting. You guys remember about blood transfusions and the different types of antigens that go with them, right? So type A blood, the antigens you have are anti-type B. So if you get a type B, they know right away. And the alternative is true. If you get, we're going to be talking about blood transfusions here next week. Yeah, I think it is. If you get a little bit of blood in your system, you'll have a reaction right away. If you're getting the wrong kind of blood, your patient will know right away. So one of the things we do when you get blood transfusions, we go very slowly. The first 15 minutes, you're going like drop. In fact, it's usually diluted with normal saline. So even when you're getting a drop, you're only getting a little bit drop. patient has a reaction, they'll say, and you warn them ahead of time, if it itches, you get pounded in your chest, or headache, or you break into sweat, anything that changes while you're getting this, let us know, because everybody's a little different. And you stop it. Double check to make sure. Sometimes the doctor will, you double check to make sure you've got the right one, but you've done that 3 times before you give the blood already. Sometimes the doctor will say, well, give them some Benadryl or Tylenol and continue the infusion because they really, really need it. But it's not unusual to get a reaction right away. We'll talk about antigens a little bit. Myasthenia gravis, weakness of the involuntary muscles. We'll talk more about that in neuro. Hemolytic disease of the newborn. Let me talk about this real quick. There's what they call graft versus host disease. If someone gets like a transfusion or a transplant of an organ, it actually has its own antibodies that are specific to the person that they came from. If it goes inside your body and all of a sudden it's fighting everything around it, it's called graft versus host disease. You should remember that. And membrane cells in the kidneys can also have a cytotoxic hypersensitivity. This is a pretty good diagram. It talks about your red blood cell and the antigen that's on it, and the immunoglobulin that's connected to it. If you have the wrong one, it can lyse the red blood cells, and then your body will dissolve the red blood cells and get rid of it. Some of the antibodies we were talking about, group A, group B, group AB. Group A says, I don't want any B, so you, the antigen, yeah. So it has it's anti-B is your antibodies, but the antigen it has is A. It has the A antigens. Group B, it has the B antigens, but it's anti-A. Group AB, it has both, so it can't have any antigens. And group O doesn't have any antigens, so you can give it to anybody. The best one, O negative, is the universal donor pack. If you have a hemolytic reaction, stop the transfusion right away. Check their vital signs. Chances are good while you're giving the blood, they'll be hooked up to a vital sign machine anyway because you're checking it constantly just to watch for them. Notify the doctor. You administer IV fluid. This is interesting. So you've got a bag full of blood, tubing leading to the patient. You get a reaction. You stop the blood. You also have normal saline hanging because it can only get hung with normal saline. What do you do with the tubing? Hook the normal saline up to it, flush it through. Yeah, because then they would get more blood. You disconnect it right at the side of the IV. And you can cap it, just in case. You have 4 hours, so you have to move quickly. Whenever you have one of those suspected reactions, you have to find out fast, because that blood runs about $1,500 and it goes on the patient's bill. I give my blood for free. I don't know why they charge so much for it. If there is an issue, you want to return the blood and the tubing back to the blood bank so that they can identify.
4 hours, is that just for how long the blood is good for?
Yeah.
Okay.
When you go and pick your blood up in the lab, they'll mark the time. It's 9:07. You have until 12:07 to get all that blood in. 4 hours.
Is it 4 hours from when you pick it up or 4 hours from when you spike it?
4 hours from when you pick it up, because it's taken out of the refrigerator. It is now deteriorating. It's good for 4 hours. So, do you think you should have your vital signs after you pick it up? Or before? Yeah.
So what's with the 30-minute, you have to use it within that 30-minute time frame on the patient, I remember.
They recommend you get it spiked and hung, transfusing right away. some patients can't tolerate the blood going in too quick. Most blood, bags, units are about 300 milliliters. 300 milliliters to go in over 4 hours would be how much? Yeah. About 75 or 80. But you've used the first 15 minutes, taking it out of the lab, bringing it over to the patient, talking to the patient, making sure you got the right patient and the right blood, double checking with another nurse. You always have to have another nurse. Now how fast do you have to go with that? So, I usually run at about 85. If the patient is fragile, I might go a little more slowly, but we want them to get all that blood, so. Okay, take a quick break. 10 minutes.